But thank you everyone for joining. This is the second time we are holding this workshop. We held it the first time before on the day of the STARR Summit, and it was really, really popular. So I'm really glad to see you guys, and I'm going to hand it off to the panelists. So we have Susan, Mina, and Joe here, and I think they will all introduce themselves so we can get started. Thanks.
So I'm Susan Weber. I'm the Director of Engineering for Research IT and the Stanford Emerging Apps Lab. I've been with Stanford for a good 20 years now, and they're brilliant. That's the deck. And it's my pleasure to be joining Joe Pallas and Mina Liu to be talking to you today about STARR Tools, Cohort Discovery and Chart Review. Joe, you want to say who you are?
Oh, sure. So I'm Joe Pallas. I'm a software engineer, and I am the principal maintainer of the STARR Tools that we'll be discussing today. I've been at Stanford for 5 years, and I'm an alum.
That's right. Great. And we'll be, Mina, do you want to give a quick thumbnail introduction? Mina has a separate slide deck. We'll be looking at her
Sure.
later.
So my name is Mina Liu. I'm in the Research Informatics Center. I've been there about 4 years. I also am alum, not in computer science, so economics, econometrics. So and I work on various concierge consulting vending or data vending, and help out with office hours as well.
Fabulous. Thank you. Why don't you go to the next slide? So we're going to be splitting this into roughly 2 segments. We're going to start by talking about STARR Tools, where the information, what STARR is, where the information comes from. We'll give you a quick dive of the tools, and then we're going to take a bit of a break, and then Mina will talk about what the Research Informatics Center does, and then we'll throw the floor open to questions for all of the panelists. That being said, if you have a question, feel free to, Priya, what's the standard?
So,
if somebody wants to interrupt, can they
people
put it in
have
chat?
been posting just a couple of questions in the Q&A. I'm monitoring that. So far the questions have been like, where will the deck be recorded? So I will send out the link after it's done. Yes, we can see you all. The way this webinar is set up is just the panelists. So yeah.
Good. So yeah, feel free, if somebody pops up with an interesting question pertaining to what's currently being discussed, feel free to interrupt. I want to try to keep this relatively dynamic, but we do want to give everybody a chance to present some content. So very briefly, STARR Tools. If you're here, you're interested in the Cohort Discovery and or the Chart Review Tool. These are 2 web applications that, web applications that let you explore EMR data. Go ahead, next slide. Where does the data come from? It's a whole ecosystem of different sources of data at Stanford. There are 2 hospitals at Stanford Medicine. One is for adults called Stanford Healthcare, and the other is for kids. They both have their own independent implementations of the electronic medical record called EPIC. To further complicate matters, until about 5 years ago, Lucille Packard was called Lucille Packard instead of Stanford Children's, and they implemented a totally different EMR called Cerner. We have 2 hospitals also share a few really large services. One of the services they share is patient identity. If you come to Stanford as a patient, you can go between the 2 hospitals, you'll still have the same identity. The radiology department is shared because it generates so much data. It's measured in the petabytes. There is one set of radiology servers for both hospitals. The third shared service that I'm aware of is the clinical laboratory, because it is a physical building with a lot of pharmacists, and it's just really expensive to operate. Both hospitals use the same lab. There may be other smaller shared services that I'm not, that are for, I think there may be some on the administrative side, but in terms of clinical, where the clinical data comes from, those are the big ones. So when you get data for research, it's coming from a large number of end systems. There are not, in addition to the main shared systems and the 2 EMRs, There are also hundreds of these clinical ancillary systems that serve specialty purposes. There is something called Trauma One that is deployed in the emergency room for triaging trauma patients. There are Philips bedside monitors deployed at both hospitals from a variety of, well, Philips is the primary vendor, but there are also other vendors. There's cardiologists, 2 cardiology departments. There's just, it's a complete chaotic mess of specialty systems that we are trying to aggregate for research purposes. Next slide. So what we do in order to make this data work for research is HIPAA comes into play. You have to be sure that you are looking at data that you're permitted to use for research. So we actually have a layer of compliance filters that we pass all of this data through before we dump it into our research ready database called STARR, the Stanford Research Registry. STA is for Stanford and R for Research Registry.
Or repository, I think.
Repository. Brilliant.
Yeah, there's a clinical data also in there, but never mind.
Next slide. So what does the term STARR include? That seems to it's somewhat variable. Depends who you talk to, what they are referring to by STARR. A lot of people tend to misapply the term STARR to refer to the STARR tools, but in fact, STARR refers to an entire ecosystem of clinical data and the accompanying tools that are approved for research use. So it includes not only the STARR tools and their custom data model, it also includes OMOP, it includes de-identified DICOM, it includes real-time research alerting, it includes these other handful of other clinical ancillary systems data that we've managed to obtain for research purposes. So it's much bigger than just the web tools that we're discussing today. Next slide, please. The data in this over-encompassing warehouse has been growing over time. Until about 2008, we did have an electronic medical record implemented at both hospitals. It was called Meditech. Very minimal, really mostly for just keeping track of patient billing. All of the clinical information was appallingly enough written down on pieces of paper. Then around 2009, things really started to take off. They started to convert their paper processes into the actual electronic medical record. And every year after that, we've seen a steady increase in the amount of electronic data that is available on patients at Stanford.
So Susan, there's a question. What are some examples of clinical ancillary data?
One example, the most obvious and visible example, is DICOM images. It is DICOM images are like when you go to get your broken wrist X-ray, you get an X-ray that is actually a digital image in a very large digital format. It takes up a lot of space on disk. You can get copies of these X-rays or MRIs or CT scans in STARR, but it is not part of the EMR. It is captured in a separate system. It's not part of EPIC. It comes from the radiology systems. Another clinical ancillary system that we know how to disseminate are the vital signs waveforms in STARR Wave. So there's a long list. If you want clinical ancillary data that isn't in STARR, just ask us for it. Your video is down. Zooming back in, types of data. Okay, now, so that was the big picture about what is STARR and what data is in STARR. Now I want to zoom in a little bit to talk specifically about the STARR Tools data model, which is the subset of STARR on which the STARR Tools operates. So what do we have in the STARR Tools data model? We have billing codes for diagnoses and procedures. We have ADT, which stands for admit, discharge, and transfer. We have visits, encounters, inpatient and outpatient. We have test results. We have test orders. We have a lot of notes, documentation, a lot of free text, clinical documentation, procedure reports, We even have smart forms, and as of next week, we will have EPIC questionnaires. We've got medication orders, which is all we know about outpatient medications. We have inpatient drug administration records. So it's really a very broad swath, but I think the point of this slide is that it's not comprehensive. So what is not in the data model used in the STARR tools are things like DICOM files, clinical ancillary data, billing records, when it was they sent out the bill to the patient, that kind of thing. So there's a lot of electronic medical record data that hasn't made it into the STARR tools, but it's like a 90% useful thing. Next slide, please. Now I'm going to zoom back out, and that is not formatting well. Going to zoom back out to talk very briefly about.
Susan, there's another question from one of the attendees. Do the data include patient risk assessments? For example, patient risk for 30-day readmission?
That would depend. Have them open a help ticket that with Mina from the Research Informatics Center. I don't know the answer. It's a very specific question, and if it's not immediately obvious, the answer is very likely we can get it for you, but it's probably not available in self-service. So very briefly, I do want to warn you all that while it's very tempting to use the self-service tools to get lots of data, lots of clinical data for research purposes, and then start creating hypotheses and studies just based on the data, I do need to warn you that there are large pitfalls that you can trip you up if you're not going into it with your eyes open. The first thing you need to keep in mind when working with clinical data for research purposes is that the clinical data you are looking at was not collected with your research question in mind. It was collected by busy clinicians who are trying to care for their patients. So the clinicians will take shortcuts sometimes intended to communicate with each other. They will use shorthand. People, when reading stuff that's been recorded in the electronic medical record, people's eyes skip over the obvious bad data in a way that computers cannot. Sometimes the intent matters. One of my favorite stories is from a project that we've been working on for years about breast cancer. In order to find a cohort of women who had breast cancer, we started off with using billing codes in the expectation that if they had the billing code 174.9, that it meant they'd had breast cancer. Well, it turns out after 2 or 3 years, we realized to our horror that if you've gone in for a prophylactic mastectomy because you're afraid of breast cancer, you've never had it, but you're afraid you're going to get it, they use the same code because the procedure is the same. It costs the same, the reimbursement is the same, and therefore they use the same billing code, but it has this very, very different clinical meaning. The oncologist was appalled that she had these healthy women in her cohort because she had been assuming that it meant that they had actually had cancer. So it's that kind of thing. You need to really approach clinical data with a lot of suspicion and try to not have any assumptions about what any of it means. And the strongest science is to use protocol for collecting your own research data in a controlled manner. Next slide. I think it's very similar. Some more caveats. Don't rely on the death data that's in the data that we offer you because it is extremely incomplete. There's just a lot of compliance worries that you need to bear in mind. We are making every effort with these systems to enable your research, but we don't want you to rely on it over much. So yes, so please be patient. It really does help to keep your expectations low. So I'm hoping that this 5-minute digression has reset your expectations to expect to find really, really bad, confusing data in these lovely tools that we are going to talk about.
Susan,
Next
another
slide.
question. Sorry, I keep
Oh,
interrupting.
yeah,
but
this
I
is
think
great.
it's best
No.
if, yeah.
Yeah.
So while creating patient cohorts in STARR, we cannot create cohorts by different providers. Can we pull out cohort data by individual providers in any other way?
Let's defer that question until the demo, because in fact, I believe you can. Let's get whoever it is who asked that question to give a provider name, and I'll show you in the tool how to do it. Next slide, please.
Okay, wait. Can I go back for a second?
Yes.
I want to inject something because although the people listening, I think should already know this, but there's another thing that isn't explicitly called out here on these slides, which is the EMR record itself is a very incomplete way of capturing the health history of the individual. One of the things we didn't mention here is Stanford is a tertiary care facility. Many of our patients get their primary care elsewhere, and we do not have the information about their and other encounters with the healthcare system.
That's a really good point.
The other thing to be aware of is just that the kind of bias that can creep into your data because what's captured by Stanford is not necessarily representative of the entire experience of the patient.
Well said. Thank you. Okay, so now, Joe, would you please click on the STARR Tools link, and let's start taking suggestions for, you may need, hey, that's, yeah, it's the wrong URL. I will click that. You know how to get to STARR Tools. So the first thing to note is this terms of use is a funny story associated with this. There was a New England Journal of Medicine article published from data that was gathered using cohort discovery searches, and it caused quite a stir at the time because the people were alarmed to think that clinical research was being conducted on the clinical conclusions were being drawn from what was supposed to be a research system. I think that sensitivity may no longer be quite as high as it used to be, but that's what this terms of use is supposed to be for. You're supposed to be cautious about the use of this data.
Yeah, and if you review the information from the IRB about what constitutes research, one of the things they will say is if you're planning to use it for clinical decisions, it is not research, and that means that it is not appropriate to use research data from their perspective.
Fair enough. Yep.
Speaking of which, there's a question about reasons to use STARR instead of EPIC. Yeah, regarding the distinction between research and clinical data. Do you want to take it on, Susan?
It has to do with intent. If you have questions about whether you should be using research systems or EPIC, please talk to the experts at the Research Compliance Office.
So EPIC is only supposed to be used for clinical purposes.
EPIC is the clinical system of record. However, there are enormous set of complicated regulatory requirements placed on research. So historically, all research was conducted at the school and all clinical care was conducted at the hospital. Clinical care continues to be conducted at the hospital, but research is slowly making inroads in the hospital settings, more rapidly at children's than at the adult hospital, but it is absolutely happening slowly, but certainly. So we're gradually widening the door. But the beauty of using the research tools is that you know that you can do research on it, that it's totally safe, it's HIPAA, it's ready to be HIPAA compliant. There's all kinds of safeguards and processes around this data. So it's just really reassuring to use this system because then you know that you're doing all the right things. There are a lot fewer guardrails when you attempt to conduct research using clinical systems. It's not to say it's not possible, it's just it's a lot harder. So what are we looking at? Go ahead.
It's kind of obvious, but if there's any kind of interventional aspect to the research, then it is going to be part of the medical record. If you're administering experimental drugs or that sort of thing, then yes, that's going to be part of the medical record.
Yep. So all those protocols already do all that. And it, like I said, it is much harder. I think the research that mostly uses STARR tools tends to be data heavy and not, if you're doing interventions, then you're collecting your data using REDCap and you're not really using STARR tools. You've got a whole different set of tools. So what are we looking at here? This is cohort discovery. So the purpose of this tool is to let you figure out how many patients match a certain clinical criterion. So somebody came up with a question about finding patients for a provider. Can you click on Encounter? And click on Select Provider. Does somebody want to type in a name? Who was it that had the question?
So I think the name was Dr. Matthew, TTHEW, Matthew Smuck, SMUCK.
There you go.
Okay, there we are.
Yeah. Okay, and then you hit count. So it's as simple as that.
And there we are.
Easy.
And so she has a follow-up question, which is, I need to pull a cohort both by procedure code along with providers. Can I do both?
Yes, please. This is brilliant. I love it when the audience anticipates. So what happens? What are we looking at here? So we have a single constraint that has drawn a box around 9,500 patients. If we wanted to make it a larger, if we wanted to add a provider, you click that little gray box on the right and you start typing someone else's name. If you want to make it smaller, you want to, right, exactly.
I'm emphasizing, yes, that it's an or when you add another one inside this one constraint.
And go ahead and drag a procedure. Which procedure was it that you wanted to search for? If we've added underwent procedure, what we're doing is we're narrowing this size of the search. We're adding an additional constraint. So this is an and. When you add stuff from the top level, you're creating a list of anded.
So I don't have a procedure yet.
Okay, so he's in physical. Let's give what do rehabilitation people do? Oh golly, I don't even know. Underwent procedure. Biopsy. I don't know. Let's there and see what the intersection is.
Or there's going to be a lot of biopsies here.
Yep, that's fine. We're just looking at the intersection. So can you? Okay, so the other thing to be note about this. So as you scroll, you see that the word biopsy is highlighted. What you're looking for is you're looking for a higher level code. I don't know if everybody is aware, but ICD-9 codes are really nice in that they are hierarchical. So what Joe is doing now is he's trying to find a higher level ICD code that is a grouper for all of the biopsies.
Here we go. Joint structure Brilliant. Looks likely for rehabilitation, doesn't it?
That looks good. Okay, so now let's count that.
But now I'm concerned about the date range here.
Oh, okay. So
there aren't a lot of these.
That tells us that this particular code was only in use in the early days, and so it's not currently being used. So that's the other thing to be aware of when we give you this data. It will come and go over time as these EMRs came online and as coding systems changed. So you're going to need to navigate temporal disturbances in your data stream.
So she's come up with the procedure. It's radio ablations, and the code is 64635.
64625.
635.
635.
35.
Destruction by neurolytic agent. That looks like it. The top one.
Okay. Yep.
Yeah. All right.
All right.
Let's see.
See what we get here.
So that's what we just searched on here was called a CPT code. So CPT codes are used for, if I remember correctly, primarily for outpatient reimbursement. They are highly specific. Ideally, as this researcher has been, ideally you already know the clinical practice and have a list of CPT codes. But if you don't, so there you go, there's the answer. 320 patients of this doctor have had this specific procedure. And then what
so
you do.
so let me point out though that this says there are 320 patients who have had this procedure and have seen this doctor. If your question is, was this procedure done by this doctor? This query is not going to answer that question.
Correct. So what you want to do is you want to add a pair of events constraint such that it underwent procedure. I would say the encounter precedes or follows by less than 5 days.
1 day?
10
Okay.
days. Yep, I don't know.
I
Try
don't know.
one. So play with it. So again, this is so what you're seeing here is we're hesitating because what you have to understand is that the clinical workflow involved in generating data for a patient is a bit chaotic. Only 20. Try limiting it. Try adding it to like making it 15, because it may be that they don't bill right away. It could be that the data comes in later. So yeah, it's a journey. There you go. So you picked up a few more by extending the range of the billing.
So I had a question here, like, even if the data comes in later, doesn't the date of the event still be the correct date?
It should be.
The provider
and a lot depends on when information gets entered into the EMR. For inpatient things, it's frequently when it happens or shortly thereafter.
But at this point, what you do is you create a cohort for chart review and you look at the data and you conduct chart review to answer your own questions. So go ahead and create. Let's go to the next part of the demo.
Ooh, okay. I'm gonna save patients for chart review.
Just use 13655. That's fine. Now here you can de-identify, or you can get fully identified if your IRB permits you to have fully identified. But for this demo, we'll just go ahead and create it de-identified.
So actually, if you don't have an IRB, you can get de-identified some chart review patients, right?
Correct, correct. And that's all described on, I think Mina is going to go into some of that. There are ways to get this data before you have an IRB for prep to research.
And
actually, I was not planning to go through that.
Okay, well, we can talk about that. That can be something for the question period.
This is just a little warning for people, because sometimes people have the DPA that allows them to access PHI and they want to have PHI, but they forget to click the box that says they want to show PHI, and then they're unhappy. So we try and catch them. We try and warn them before it's going to waste a lot of time and effort.
So just before we actually go into the chart review, there were a couple of more questions that came in. Can you use generic terms such as biopsy or CT scan, etc.?
Yes. So it depends on the constraint. There is one constraint, I think specifically procedure constraint allows you to search just on a word. Almost all the other constraints actually require you to pick something from the matching drop down. So you have to play with it.
And then the other question is, well, if the coding has changed over the years, do we need to include all possible codes per date range?
Potentially,
Sadly, the
yes.
answer is yes.
There's a lot of overlap. There is a lot of the codes were mapped.
Mhm.
There was a genuine effort
Right.
to create a crosswalk. So if you use the more modern codes, which are the ICD-10, it will
Yeah.
include many of the older, but there is some stuff that is so old that it comes from our HL7 record that it was not cross-mapped. And so, yeah, if you want the really, really old data, you have to use the older codes.
Did you mention as well that there are some procedure codes that may be linked to, like, for example, older ICD-9 codes, even, and the procedure might be occurring today, but it may still pull an ICD-9 code?
So coding is no longer done with ICD-9, but they are cross-mapped in the underlying data. All new codes, I believe, are coded using ICD-10. But depending on how the data is delivered, you can also get so what we try to do when we deliver data is we try to give you not only the current code, but also its analog in the other coding system. Does that answer your question?
Sure, yeah.
Yeah, this is an area where unfortunately it kind of helps to know a little bit about how Epic stores data internally, which is that it's not using ICD-9 codes or ICD-10 codes. It's using procedure IDs, which are arbitrarily assigned numbers that are used to identify every possible procedure that the hospital or clinics could perform. And then those get mapped to ICD-9 codes and ICD-10 codes for billing purposes.
All right, and they get retired over time. Some of the older procedures, even though they're similar, they've got new procedure codes for them because the billing parameters changed. So yeah, it's a journey. So let's, if there are other questions about cohort discovery, we can field them in the general question hour at the end of the workshop. What we're looking at here is chart review. So you'll see immediately popping out at you that a handful of these patients are already deceased. This information may come from the EMR, or it may come from the Social Security Death Index. We get a copy of Social Security death data and we do our best to accurately link to it. But the death index is unfortunately very sparse because of a change about a decade ago now, where unless it is directly reported to the Social Security Administration, they can't re-release it. So it's really hard to tell whether or not these patients truly are still alive. So be very cautious when using date of death information from STARR Tools. So this is a list of your patients. On the right-hand side, there's a little panel that shows you how to get data for this list of patients. You can tick the boxes and push the button to ask for data out. And then the bottom corner, there's some graphs. The idea behind chart review, the original concept was that you would look at each chart and then you would decide whether they were in or out, whether you wanted to include them in your study or exclude them. And so those graphs will gain colors depending on how many you've included or excluded. Right now, all the bars are gray because everybody's undecided. But if you were to go into the top record, woman born in 1960, it'll take a minute because we just provisioned this. But ordinarily, after you've waited for a minute for the first patient to load, all the other patients will load much more rapidly. The servers right now are caching the information and preparing it so that it'll load much more quickly next time. But yeah, this will be a screen similar to reviewing a chart in Epic. It's going to display all of the available information in a format that you can hopefully easily search. If you go back to the patient list, we can display, we can demo how to search across the whole cohort. Oh, and actually, the other thing you could do is you see that drop down. We'd click on the drop down. This is how you navigate between cohorts. See that very small down arrow. That's how you switch between different cohorts that you've saved. It's a little.
I may not have
You
any
don't
other
have another
cohorts in
cohort.
the
Fair enough.
production system.
Fair
if,
enough.
if we were looking at the development system, I'd have dozens.
So no worries. So in the upper right, you want to type in, I don't know, liver, I mean, just some random word. And we'll demonstrate how you can search through your list. Or shoulder maybe, because these are all supposed to be rehabilitation patients. I guess this hasn't been, oh, this won't work yet because it hasn't been indexed yet.
Yeah.
Okay. Yeah. Next time we do this, let's have a demo cohort
pre-indexed one. Yeah.
Yep. Okay. So, but by now the first patient should be loaded, I would hope.
Wait, oh, that's trying to search.
Oh, it's still trying to search. No. Yeah, so if you get this slow behavior, it just means that your impatience is outstripping the system's ability to respond, and you just go pour yourself a cup of coffee and come back in a minute, and it'll have reset.
Yeah.
While we're waiting, do you want to click on the question mark in the upper right?
So Susan, there's a question. I think you kind of partially answered that, but the question is the step that you're doing right now. Do you need IRB approval for doing that before accessing?
If you want to just do prep, it depends on your intent. So if you are in a preparatory to research phase, Joe, do you want to open up a tab to the STARR Tools.html thingamajig website, and we can show people. Click on data compliance. So this is a really, really useful website. It's got a ton of information about STARR Tools, and I've tried really hard to write it in a really clear and understandable manner. So there are 4 options to consider. You can create a new IRB protocol. You can modify an existing IRB protocol. You can, wait, did we skip one? Where is intent? Actually, go back to self-service chart review. Where is the description of, here it is, step-by-step guide to self-service chart review. So prep to research. If you are still in the preparatory research phase, you can provision yourself a chart review of up to 50 de-identified charts available for 90 days. So, and then if you click through that link, you will be walked through how to do that. So that's how you get to chart review before you've had an IRB. It is time limited. It is limited in the number of patients that you can see, but you can play around and you can review de-identified charts. But as soon as you decide that you are going to conduct research, you absolutely must have an IRB protocol. We can go back to the, let's go back. I wanted to show the question mark and how to get in touch with so if you have problems with the tool, if it's giving you stack traces or it's not doing what you want, what you do is you click on report a bug, make a suggestion, and you start typing in your what it is that you need us to know about. And then in the bottom right is submit feedback. This will send an email to the people who actually maintain the tools. So this will not, there's so much room here. I know, it's like, yeah, and it also doesn't capture anything about what you're currently doing. So if you do use this and you're trying to report a bug, please write an essay about exactly what you were doing, what the name of your cohort was, what you were attempting, try to catch your screenshots, and then just sort of really be specific.
And you put screenshots in there?
Not sadly, no.
Not at the moment. I should add a way to add attachments. I'll ask Srini to do that. Search failed, no index found. So that's fair enough. We expected that. Yeah. It's at 3%. So yeah, can we, is the first patient indexed yet? Here
yes.
She is. Okay. So now the first thing you want to do when you open a chart is you want to click on the thing on the right-hand side, date, to make sure that it is sorting in the correct direction. It looks like it is.
Yes, we fixed that, so it's the default now.
Good. So what you see here is a time series lists, you want to drag the splitter bar down so they can see more of this wonderful stuff that is now here. This is a very, very, very long, this is apparently fairly sick patient, very long list of every single item of information that we have on this particular patient. And this is where the search in the upper right is really going to save your bacon, because what you're looking for is for encounters with this doctor. What was his name again?
Matthew Schmuck.
Schmuck. So type in Schmuck.
Was it Schmuck or Smuck?
Smuck.
Schmuck, my bad.
Yeah.
Okay, and then now all of a sudden, do you see how the scroll bar on the right hand side suddenly got a lot bigger? That means there are a lot fewer records showing. So now these are all the records in which the word Schmuck appears. And so you can use this to scan. Oh, it looks like 2018 was the year that this patient was seen by Dr. Schmuck. There, 2019 is showing up. 2020. Okay, so yeah, so ongoing. So those during COVID and beyond. So that means that when you go back, if you click on the show all button to go back to looking at everything, you now know where to zoom in to start hunting through the record for this.
So there's another question. If you have IRB approval and have gained access to de-identified charts, are you able to manually review information from Care Everywhere?
At this time, I think Care Everywhere, you need to have reconciled the information to make it part of the electronic medical record. So what we have access to is what is in Epic's database. Care Everywhere operates in two modes. It operates as a window for the clinician to peek into someone else's medical record remotely. But until the local doctor has taken some steps to import that information into the Stanford record, it will not appear in STARR. So talk to your doctor. If you want to conduct research on a doctor's patients, tell that doctor they need to reconcile the Care Everywhere records if they want them included in the research record. Once it's there, it'll just show up.
So there's another.
Yes. But generally, my understanding is that's intended for clinical care,
right.
not for research.
Yeah.
Correct. Yep.
Exactly. If you're not involved in clinical care, it's not clear that you can use data from other EMR systems if it hasn't actually been imported into our system. Exactly.
It's got to have the physician, the local physician has to have reconciled it and imported it to make it part of the Stanford medical record. And then it is okay to use it for research, but not before. I'm going to actually time check. I think we're at 45 minutes into the hour. I'm tempted to suggest that we let Mina have the floor.
Questions can we answer those and then get to Mina? So
sure. Yep.
When looking for scheduled procedures that are not yet performed, do I just put a procedure date in the future?
Yes, that's my understanding. Can we go back to the Cohort Discovery Tool? That's a good question.
I'm not sure.
Do we not have the schedule?
If it's, I mean, because procedures.
Let's go back.
You have an appointment. You have an appointment, but I'm not sure that the appointment actually has a procedure associated with it.
Let's play with the data. Let's screw around with the go switch from here to Cohort Discovery. So it would be encounter in the future, right? And not procedure. So procedure I know wouldn't have it because procedure is
right.
Billing codes. So you won't have been billed if you haven't shown up yet. So go to encounter.
Right. So you can have an appointment with a provider or a clinic.
Yeah. So clinic. So type in clinic. And then type in something random, I don't know, sports medicine, and then type in an event date in the greater than today, and let's see what we get.
Okay. What day is today? It's the 28th.
28th. And 28.
Yes. I'm trying to mentally do that conversion from October to 10. It would be so much easier if October were 8. Okay.
No, you're right. Oh my God, now I'm not going to be able to unlearn that. So yes, so we have some data,
a
but
few.
it's not clear that it's everything. So again, what you have to do is you have to mess around with the tools, save for chart review, look at the data, compare it to what you expected, and just that's why we warned you that this is not the greatest source of pure data for research. You need to really, really dig in and understand what the limitations are, because even we don't know what we have here. I mean, it's just.
There's another question saying, are there office hours or something similar to get help for individual cohort searches and questions? I think Mina is going to address that.
Yeah,
Correct. Yep.
Yeah, and then there's a suggestion that tutorial videos using STARR Tools would be to watch on demand would be useful. And if you guys are okay with it, I'm actually happy to add this as to the list of the STARR video tutorial under the tutorials list.
Yep, that's fine.
Perfect.
there was also a question about and or, how to combine them in
Oh,
searches.
that's right. Yeah, that was a cohort tool question. So yeah, if you could go over how do you know the logic between when do you use or and when do you use and in the cohort tool again?
Yeah, Joe, you want to field that one?
Yeah, sure. So each time you add each of these gray boxes is a constraint, and within one constraint, you can have or operations. So I might say that I am interested in someone who went to the sports medicine clinic, or they went to I don't know the clinic names. Maybe there was sports psychology. Yeah, that's good. So I might be interested in people who went to either sports medicine or sports psychology, and they had some, oops, what I wanted to do, go away. Thank you. And they had some procedure, shoot, I don't know. I'm just making stuff up here. And so now at this point, I have an option. If I were interested in another procedure, if I wanted to say they had this procedure or that procedure, then I would use the addition of a new or option within this constraint. But if I wanted to find patients, oops, I meant to click the minus. If I wanted to find patients who had this procedure and another procedure, then I would add another procedure constraint at the top level. So each of these gray boxes is an and with the other gray boxes, and the or is within the box.
So there's a clarification that they meant for the chart review tool,
Yeah.
doing and or in the chart review tool, which I'm not sure if it's.
Yes, so that's a great question. If we're talking about searches in the chart review tool, yes, there's absolutely a way to use and or. So that is mentioned in the chart review tool users guide. Joe, do me a favor and go back to the tab where the documentation is, and click on chart review user guide and scroll down to the bottom. There should be a description, or is there a link to a Word doc? Where's that nice detailed Word doc about
Stuff here.
Is it consult the users?
user's guide? Yeah, in the middle of
that.
the page, consult the user's guide. Click on that link.
Yes.
Okay, now scroll down to the bottom. So here is a very detailed user's guide, and scroll up a little bit. Here is the section on how to search using and or. So you can use the word and all caps, or the word or in your search string, and that will absolutely.
So she specifically is saying user guide tells you how to use and how to use or, but not how to use both in one search.
That is correct. We do not yet support parentheses because that is too hard. So what you have to do is piece it together. I'm sorry. Parentheses are out of scope.
It's so powerful. I'm surprised it doesn't have that.
Well, we can look at, I mean, if we wanted to, we could have a power user mode where they type in a regular expression, but it's just, this is designed to be the 80% simple enough for everyone to use for 80% of their needs. And if indeed what you're looking for is a really complex search, perfect segue. Mina, take it away.
Okay. Did you want to take the 5-minute break or should we?
Yeah, let's do a quick straw poll.
Okay.
If people want to step away for 5 minutes, refresh their coffee.
Yeah, we can start again at around 11. It's 10:50.
Okay. Okay.
Perfect. See you guys
That's good.
in
Okay, thanks.
6 minutes, 4 minutes. All right, take it away.
Okay, I will start my screen, but hold on. Okay. Okay, so we're going to move on to the portion where we'll talk about the Research Informatics Center and our access to STARR data, what we can do for you. So we'll go through why you might want to come to RIC, when in the process you might want to come. We'll look at the basically look at the request for a consultation form. See if just pretend to fill out a sample project, and we'll talk through an actual project that I've been working on, and then leave time for Q&A. So there are different services that we offer at RIC. So as I think Steve mentioned that, are there office hours? Yes, we offer office hours where you can come and ask questions about the self-service tools. You can talk to us about, how do you execute a more complex search? We can also help with expanding your cohort size because there are limitations on how big you can make something. And maybe just get some opinion about or input on how to structure your project. We also do the front door for ancillary data requests. So this for these clinical ancillary systems, DICOMs and some other waveform formats. We also have access to the OMOP PHI data set. OMOP is it's kind of a cross-institutional data model that has been created to be able to communicate more effectively, share tools across institutions, share the same sort of nomenclature. And Priya's team has actually taken the STARR data and put it into that OMOP format. And there's a de-identified version and a PHI version. And we do have access to the PHI version, the one that has the PHI maintained in the data. We also have some access to various registries, cancer registry. And then we also offer concierge data vending where you tell us what you want and we will go get it for you. So the advantage of that is there are some limitations on how you can, how you can formulate the searches in STARR Tools. We can do some more complex sorts of linking of the data. We have access to some other data tables that may not be available either in STARR or it's just hard to find them. And then we have some experience and the tools to be able to speed up the data, know what to expect, know where to find things. And then, we just have like a broader view of all the clinical data sources at Stanford. We have access to what's called the full clarity, which is the data set that's kind of brought over with some filtering from Epic. We have, we're familiar with the data dictionary. We have some access to some search tools to figure out where things are. And we just have done a lot of projects and know what some of the pitfalls are.
So
Okay, so
question
yes.
asking, are the tools available through STARR OMOP similar to what the concierge data vending can do?
Okay, so do you want to answer that, Priya?
Sure.
Okay.
So think of it as the raw data source is Clarity. There are a bunch of data models that we support on that EHR data. So the data model that Susan showed you is one data model. OMOP is another data model. And then we have some self-service tools on both of these models. So the self-service tools for the legacy data model, which is what Susan was showing you, is the STARR Tools and the Chart Review Tool. For OMOP, it's Atlas and ACE. So you can create cohorts, using the STARR OMOP data model. But the concierge data vending can actually give you, more stuff than just what you can do with the self-service tools.
Okay.
You guys want to add anything to that?
No. Okay, thanks. Okay, so in terms of your kind of the rough process of, you're formulating a research question, where we can help is often people come to us kind of after they figure out what they want to research, but they want to see, are there enough patients or what does the data look like? And so they may come to us to get some input on that. Then you would go back and get compliance for your research project, work with IRB, figure out what exactly you're looking for in terms of data and talk with the statistician. And then we would come in after that and then help collect that data, aggregate it if necessary, do some processing of the data, kind of to maybe you want the last occurrence or the first occurrence or things like that. So we can help with that. I cannot see because Zoom has got the screen over it. Okay, and then you would take the data back to the statisticians to analyze it, do your writing it, and have great scientific impact from there. So we're going to start now. If you could open up the RIC, there's a link down there to our page, and we can go through. You are welcome to put in a pretend project and just put test or something on there to make sure that you are putting in what popping up questions that might come up as you're putting in your own project. Just put test or something in there. So this is the page that you would get. Wait, no, that's not the page. Let me just click on that. There we go. Does it work when I do this? I'm not sure if it works. Okay, so I think what it takes you to, if I remember correctly, I'm sorry, I had the page up and not done it. Yeah, okay, this is the page it would take you to. There's the information on the data workshops here, but further down, you'll see looking for research informatics help with Stanford clinical data. You can start here and also submit a request here. And so we are going to go to this page next that describes, gives you some different sources. Like if you want to try doing STARR Tools data, there's also something called a Research You Succeed STARR Capabilities form. It used to be called EHR Access Form, also called STARR Insufficient. And so that would be a case where you want to use Epic for research, even though you're supposed to be directed towards using STARR. If there are certain things that you can only get through Epic that you need for your research, you can click on that link there, fill out the form, explain why, and document your reasons, and then that would be sufficient. So you actually don't need to, in the past, you had to actually have a consult with us, but you no longer need to do that. So you can just fill out that form. There are some other things about, if you're going to be using the data for recruitment, you should contact the engaged participants at Stanford for information on that. And then once, there's also a link to office hours, but you do need to actually fill out this form first. And so you would put down, who you want to be contacted, their contact information, what department you're coming from, whether you're funding, etc. And we actually have a special group that focuses quite a bit on cancer data. So that's one of the reasons we are asking if you want cancer data. And then
you might want to go full screen on your PowerPoint. It's a little hard to read right now.
Okay, there. Is that better?
Yes.
Thank you. Thank you for letting me know that. Yeah. And then just, project name, and then just briefly what it is you're looking for in your research, and then what your, sorry, I'm just realizing I'm behind on the little pop-ups, and then what it is you're looking for from us so that we can have an idea of how to prepare. Okay. Then if you scroll down on that intake form, there's, some more space on what is your question. The bottom part of this page is actually in this clinical ancillary data. This is on the right, you'll see a list of the different types of data that that are available. When you click on those, typically you'll get another part of the form visible, so you can enter in some more data about maybe how you want the data formatted, where you'd put it, what sort of project, the GC Google Cloud project you might want the data stored in, things like that. Then there is a note here that we would, you will get a response by email, and then you can read that email carefully. There should be a link to office hours if that's appropriate to your needs.
So there's a question for you, Mina. Can you give
Yes.
an example of when you may want to use Epic over STARR, or when research exceeds STARR capabilities?
Yeah. Let's see. I'm not sure if I don't think.
Well, Joe mentioned earlier.
Well, no, I'm sorry. I actually have something. So I had somebody who wanted to know, so all the operative data is not that easy to get in STARR. And so you can look through the notes, but there is some, sometimes that's more visible in based on Epic, the way there might be a tab based on that, or sometimes the ambulance reports. I had to look that up one time. That's not in STARR. Do you have some other ideas, Susan?
Well, so anything that's in the blob server, as you say, PDFs, right. Any kind of information that comes in, genomics lab results that come in from these labs in the Midwest, they fax the results back and they attach the results of their genomic assay to the patient record as a PDF. PDFs are not in STARR. We have structured data that's in their database. These PDFs are in an outside system called the blob server. So if you need to read those PDFs, you need to submit one of these STARR EHR access requests.
Yeah.
But the IRB will tell you, the IRB has actually gotten pretty good at figuring out what's appropriate for STARR and what isn't. So just negotiate it with your IRB panel. They'll help you, direct you in the right direction.
What about care everywhere data? So like the part of care everywhere that hasn't been brought into the Epic system.
It's not permissible for research use ever.
At all. Okay.
At all.
Yeah, it's part of the contract, like the way, in order to be able to use it, you're not supposed to use it in that way. Yeah, really important. Okay. And then to review some of the clinical data sources, we have, so what we have access to in RIC is the Clarity, we have STARR, and the underlying data that we're using is from Clarity, which is kind of a copy of the data from Epic, or a partial copy with filters and things like that. We do have access to Stanford Adult Hospital, as well as the LPCH data that is coming from Epic. We can get you access to the radiology DICOM images from PACS. There's the vital signs bedside monitoring, currently only for LPCH. And then, as Susan mentioned, the clinical photos from the blob server. There's also like the PDFs, anything that's stored on the media tab.
So
Yes, go ahead.
go ahead, finish this, and then I'll ask you the question.
Okay. Yeah, there's also echocardiogram DICOM images, the waveform files, hemodynamic data from the cardiac cath lab, blood transfusion data, and then we have a number of cancer-related systems, the tumor registry, ARIA, things like that, SCIRDB, the Stanford Cancer Institute Research Database. Go ahead.
So one question is, the cohort discovery has been helpful, providing a very general snapshot of what cohorts might approximately be available for a research question. But I've been asked, what type of consent does a given Stanford patient provide for just looking at any of their cohort discovery or chart review data with an IRB or under preparatory to research?
Susan, do you want to answer that? I think it's part of their paperwork.
Okay.
I know, but
Just to clarify about the blob server. So the one
Oh, yeah.
type of blobs that we do have from the blob server are the clinical photos.
okay, so not the PDFs of the document.
Right. We don't have documents yet.
Okay.
But we can get,
Okay.
but if somebody needed it, we could through a consult. So it's,
Yeah.
but there's a tagline somewhere on one of the websites saying, if it's in Epic, we have it. But that doesn't necessarily mean it's available through self-service. It just means that
Right.
you with sufficient persistence, you can obtain it for research using our services, including specifically using you guys at the RIC.
Right.
So Susan, the question was, for what kind of consent does a given Stanford patient provide for just looking at their cohort discovery or chart review data with an IRB or under preparatory to research?
That's a question for the Research Compliance Office, not for us. But my understanding is that that if you have written your IRB to have a waiver in it, then you're allowed to use electronic medical record data without explicit patient consent if it's only for chart review. But talk to the Research Compliance Office about all of the nuances of what it is you're trying to do in your research.
And then someone says, oh, to confirm, there's no way for users to access Clarity data directly.
You mean researchers?
Yeah, so I mean,
Yeah. Oh, so the Clarity data is like the raw data tables, kind of, and that so they're referring to that versus Epic, right?
I think so. I mean, I think.
Well, I think by policy, we try very hard because of minimum necessary to create subsets that are pre-filtered by us to contain patients that are suitable and appropriate for the research question being explored.
Yeah, so the question is, is there a way for users to access Clarity data directly? I think the answer to that is no.
Correct.
Not the general population, no. I mean, you would be doing querying, you don't have the STARR tool, nice user interface.
IRB, and you would have had to get a data cut from you to get Clarity.
Yeah, I mean, if you want to go crazy with all the querying, I'd recommend you access the data using like the OMOP version. There's a de-identified OMOP version that you can access and use GCP BigQuery to do all the queries. So that if that's what you're looking for, that might be a better way of going through that.
So there are a couple more questions about
Care
Everywhere. According to the LPCH clinical informatics, we can use data from Care Everywhere for research purposes, but we cannot request for more clinical information. Research staff, Epic access.
Are they talking about the data brought in from Care Everywhere or going directly to Care Everywhere?
So that
Todd Ferris was very unambiguous very recently, saying that it was not permissible to log into Epic and click the Care Everywhere link and acquire a Care Everywhere record and then scan it and use it for research. That is unacceptable according to the CIO of the hospital as of like a week ago. So if Packard is saying something else, we need to talk to Packard.
Yeah, I mean, it's part of being allowed to use Care Everywhere, is my understanding, and we would hate to lose access to something like that.
Another question about it, like, if we need something from Care Everywhere, we need to request the local physician to permit the information to be uploaded into Stanford Epic.
That's exactly right. Once it's in Stanford Epic, then it becomes part of the medical record. Maybe we could table all of these Care Everywhere questions and have a separate seminar on it, because it's a bit derailing.
Yeah.
Yeah, I mean, but it is, I guess I want to make it very clear that Care Everywhere is a research system. I think that's the message that we've been getting very, very concretely.
Care Everywhere is a clinical.
Excuse me, it is a clinical system. It's meant to be used for clinical purposes, and it's not to be used for research. Yeah. Okay. Okay, so this is actually just a kind of a screenshot of the data. It's very small, but it's the page that if you click on, I guess I can go back here. See. Down here at the bottom where it says State Clinical Ancillary Data Catalog, if you click on that, you would get to a page like this that kind of goes through the detail of each system. So like this is the radiology images, and there is a difference because the data would be coming from adults versus children's. In this case, it's kind of a shared service, but we do spell out any differences there are and give you some ideas of what's available, how far back it's available. Here's the vital sign bedside monitors. So like the adult data is not currently available. Like Susan has said, if it's in Epic, it's there. We just have to figure out how to get it. So in some cases, if it's not already available, it could take quite a bit of time in order to make it accessible. But right now, pediatric historical vital sign data is available. We have the clinical photos from the blob server, not currently available for pediatric. We have echocardiograms. There's some caveats there about, there's some missing data in some cases. There's some limitations on how quickly we can get the data. We have the electrocardiograms there's a graph of the voltage versus time, which is, different from some of the other DICOM formats, not currently available for pediatrics. We have hemodynamic data through the cath lab, not available for pediatrics. And then there's a lot of cancer-related data we have access to, and we can help get you like some of the pathology, and we have people on our team who actually have direct linkages and communicate with some of those other registries and PowerPath, things like that. And then, we have some of the blood transfusion data. Now, in terms of getting access to our office hours, once you fill out that form, you will submit it, get an email back, and it'll have the case number at the top, usually in the subject line. And so check that email. There should be, read through it. There's some things that you may need to do ahead of time. For example, fill out a data privacy attestation. The link will be there. You can then fill out the office hours request. There's a link there. Put in your case number that you received in your email. And just a note, like office hours are free, but if you want to do the concierge data pool and some of these other services, that may require funding. And so going through kind of what are some of the questions we've gotten in some of these different venues. So the STARR Tools help. There are patients, or there are researchers who come and say, like, I'm getting so much data from the data download files. How do I limit it? And so we can give you some advice on that. For example, limiting the time frame. Sometimes researchers want to save a cohort larger than, I believe the current limit is 7,500. Maybe they want to save 30,000 patients in their cohort, which it's something we can help them do with some limitations. And then maybe you just feel like you've got a very complex search set of search criteria you need help with. And then there's the ancillary data request, the clinical ancillary systems. A lot of times you will need some way to identify the image that you're looking for or the report. So you might need an accession number. You might need some help finding those accession numbers. What do I do with the accession numbers once I get it? And can I get the clinical data associated with those images, like, you know, what were the diagnoses, or what was the HCT number at the time of the accession, or when the image was taken, for example. And then you might also want to come to us during these office hours to ask about, like, planning for a data vending project. I had somebody come to me and say, can you get me the My Health messages? And that's not something, well, one, it's not something directly available in STARR in an easy format. And maybe you just want to see what's available without there. And then maybe talk through what you might need in order to get an estimate of the work. Okay, so I'm just going to go through some brief overviews of what a project looks like, what's needed for a data pool. You know, in that first few meetings, we're going to be coming up with a project overview, figuring how you want to identify your cohort, what are the inclusion exclusion criteria, index event. Maybe you want to come up with a set of codes or outcomes for your project. We will need to talk about how you want the data delivered, where you want the data delivered. You know, sometimes we're just going kind of basic and like, just give me like a Excel file, but sometimes when you've got, you know, 130,000 rows, that doesn't work in Excel so well. And so we can talk through what the options are and how you want the data to look. We need to talk about the project finances so we can get an estimate, and then we will need a PTA from you to get started on the work. Okay, now we're going to talk about how to identify a cohort. Some of this might be pretty obvious to you already, but these are questions that should be clear in your mind as you come to us. You know, what is that key event that you are looking at with your cohort, your patient cohort, like that means that they're going to enter into the cohort. And a lot of times it'll be a particular diagnosis, the first diagnosis of, you know, diabetes or something, or a certain procedure or operation. You do need to think about what sort of age the patient would be at either currently or at the time of the procedure. There is a big difference between the LPCH and SHC data in terms of where it's stored. And think about also, there are some patients who are over 18 at one hospital versus another. So just have that clear in your mind. Think about what locations. We have the adult hospital, children's hospital. We have the outpatient clinics. We also have data from things like Valley Healthcare. And so just have that clear in your mind about where you're looking. Think about the inclusion exclusion criteria kind of ahead of time, like what a lot of times people think about, like, okay, I want them never to be have been admitted for this particular diagnosis, or they should have had ventilation lasting longer than 48 hours, or things like that. So make sure you've got that clear in your mind. Think about if you want to link certain criteria, so the inclusion exclusion criteria. For example, I had a case where they wanted the patients to have had 2 CTs of their lungs, but that had to be within 1 year. So not just 2 CT scans anytime, but 2 different ones on different dates, but within 1 year. And then
we can absolutely demo how to do all of this in the cohort discovery tool. Yeah.
So, you know, these are things that you can, you know, are quite feasible in the cohort discovery tool. We can also help if you'd rather just us do them, but because sometimes I think it gets a little complicated and yeah, to figure it out and sort through the data. But yes, you're right, they can be done in cohort too. And then also it's helpful to think about what size of a cohort you are expecting. I know for, I think it's privacy, they want to know, are we talking about plus, are you greater than 100,000, less than 100,000 patients? It also affects, data delivery, where the data can go. Can it be an Excel spreadsheet versus needing to go into a Google Cloud project to get stored?
So there's a question,
Yes.
which is if I'm looking for participants in an age range that covers both LPCH and SHC patients, for example, 5 to 25 years,
Yeah.
should I split the cohort to before and after 18?
Isn't
I
that
can't think of
depend
a
on
reason
how-
why.
Well, it depends on how your protocol is written.
Oh, okay.
Right?
Yeah.
Again,
So
that's a
why
question
would
for
you
the-
do that? Because LPCH does have patients.
Correct. So just to be clear, the data from both hospitals is intermixed in STARR. So the one
Yeah.
thing on this slide that you can't do with self-service is tease it out by location. So we haven't yet built because there's so many shared services, it's really, really hard to actually cleanly separate the two. So we just give up.
Yeah. So I usually ask when I'm talking to a project and they say, I only want patients under 18. Or, I was like, do you want the patients that were seen at SHC who are under 18? So just have that clear in your mind, what it is that you are going to want to look at and what to focus on. Okay. So the other thing to do kind of before you get too involved with RIC or actually even with cohort tool is think about what are the codes you want. And I know often people know what codes they want, but I have come across researchers who really have no idea. What are the codes they want, for example, with obstructive sleep apnea? What are those codes you want? Or like, lung disease, chronic lung disease. What do you mean by that? Do you want to include asthma or not include asthma? It's good to think about ICD-9 as well as ICD-10 codes because they, like Susan said, if you want something that's, after 2015, it's mostly ICD-10 codes, but sometimes you do get the random ICD-9 code. The labs at Stanford, we typically go by what are called the base names. There's also LOINC codes, sort of LOINC codes that are more cross institutes, wider usage. So you can also look those up. The procedures, there's 3 different types of codes: CPT codes, ICD-9 codes, ICD-10 codes. CPT codes seem to be kind of the more commonly common ones. I noticed I think it was Valley Care where they were using more ICD-10 codes. Think about the encounters. If you have a department name, that's helpful. Think about what was the department name at the time that you want your research to cover, because that can change. Medication, we usually go by like the generic name or the ingredient name is helpful, but there are things like RX norm and DC codes. If you're going to be using OMOP, you will need to identify or figure out the concept IDs is the code that they use.
There's another question saying, what are lab-based names?
Lab-based names, they're like an abbreviation. So hematocrit is HCT. I'm not exactly sure how they show up in Epic.
You can think of it as a grouper.
Okay.
When we were talking earlier about procedure codes being tied to individual records that change over time, it's the same with labs. So they'll have measured hematocrit back in the early 2000s using a certain test, but then they got sophisticated and they had a slightly different test for measuring it more accurately. They created a new record for it. It's still measuring that same blood gas, but it's a different procedure, but they all have the same base name. So it groups similar lab tests into a category that is widely used by clinicians.
So Susan, I've seen like names like Chem 10, Chem 23. which is basically a bunch of, it's like
Well,
10
that's a
labs.
panel. That's different
That's a
than
panel.
base name.
Okay.
So you can,
Yeah.
there are also groups of related tests that are grouped in the order.
Okay.
Base names are associated with the results. So Chem10 will contain half a dozen base names, including WBC, RBC, HCT, ACA1C, and so on.
Yeah, the base names, like in terms of, I'm not sure what they look like in Epic, but they're basically like the abbreviation for that, the lab. So HGB, WBC, ANC, ALC, things like that. Yeah. Okay. And then in terms of data deliverables, we did want to let you know that certain things are very more straightforward to get, like the diagnosis codes, the path reports, the demographics, but there are other things that are more complex and that you require a little heavier lift. So the unstructured data, like if you're trying to pull out data from the clinical notes or from the operative notes, those do take quite a bit more time. There's if you're trying to link a bunch of things, that'll be a little bit more effort. The cancer data can be stored in kind of non-standard tables or tables that are a little bit harder to get to, or may require some more time. If you've got a custom format that you're looking for the operative data, the ADT records, sometimes figuring out what's going on with the patient moving from one place to another is not as straightforward as you might think. And then if you are looking for de-identification of the data, that is going to take a little bit more time than the stuff on the left. Okay. The other thing you'll need to think about is how you want to identify the outcomes. So kind of the dependent variable that on your project. Go ahead.
Before you go into outcomes, another question. Is there a dictionary we can access with the base names and what tests they include?
Oh.
I don't know if we do have one, but if we don't, that's actually a really good idea.
Yeah. Is Tina on the phone?
Yeah, Tina was, but Tina.
Okay.
She's
Yeah.
Well, so the chart review tool can be really handy. If you create a cohort and you get all the labs, what you get are the component IDs and the base names, and you can do a little mini analysis just on your set of patients. But you could also go to the pathology. I know that no, that's just orderable tests. Never mind. Yeah, if somebody needs it, we could add it to as a piece of metadata.
That's a good idea. Yeah, it does change over time. So that does make it a little harder to maintain the latest version. But I know for myself, it's helpful if somebody can come and tell me I want the WBCs, but I usually do also go back and say, okay, these are the things that show up under WBC. Is this what you want? Or these are the codes that I typically use for chronic Lyme disease. Are these the ones you want?
But regardless, you'd be able to effortlessly give them that data set in a custom consult. If there was, right?
Okay, I don't know effortlessly, but yes, that is something I could.
That's one of the things the request.
Yes, that's what we do.
Request, and that's what you guys do.
Yes, exactly. Okay, and so in terms of figuring out the identification of the outcomes, that is part of what what is the goal of you're trying to model. So people are looking for death dates, and as Susan has mentioned, there are death dates, they're not complete. So a lack of a death date does not necessarily mean that the patient is not deceased. So that can get a little tricky. A lot of times people do follow-up dates or, survival length, things like that in order to get around that. There's the last follow-up date. So you might want to look at what is a new diagnosis after, the index event. You want to track, okay, when did this, that liver lesion turn into lung or liver cancer, for example. You might want to see whether, how many of these patients are actually having to go into go on ventilation or have a reoperation. So those are some of the outcomes that I've seen. And then the data delivery, this is actually probably become more important as we've gotten bigger data sets. And there are, there's the Excel or the CSV, the comma delimited version, which is just a flat file or a text file separated by commas, or you can request something else that works for small files. But if you've got a very big data set, or you have a bunch of data, files like 30 or whatever, it's probably better to set up a Google Cloud Platform BigQuery project, and then we can take those data tables and put it in there for you to do the analysis. And so that we use something called BigQuery, and so that we can move that over to you to get that done. There's also I just mentioned there's the GCP Nero projects. So that's kind of it's not a playground, but it's a space for you to store your data. You can use different tools like BigQuery or R to do the analysis on that. But the Nero is safe for PHI, and that's a separate process to get that through the SRCC. You may also want to think about de-identifying your data. A lot of times, if you're sending it outside to like a different registry or collaborating with another institution, you will need to do that de-identification. It can be as simple as having the anon IDs, like just putting a number there for each patient in your record. Dates are also PHI, and so you can jitter them, which means adding a number, possibly plus or minus 30, or between minus 30 to a positive 30, where you move all the dates one way or another. You can also just go with let's just skip all the dates and talk about the age at which this procedure happened, or age at which they were diagnosed with something. And so we can get that set up for you. Let's see, and then where you want to store the data, we typically will either move it into Google Cloud Platform project for you, or in Medicine Box if it's small enough.
So there's a question. So to get the data in BigQuery format, do we need to have a Nero project or not necessary? So I think.
So in BigQuery format, I mean, let's see. So we
highly recommend using Nero. I can't think of any reason not to use Nero. It's the fastest on-ramp to successful research at Stanford.
And just FYI, Nero's being rebranded, so you may hear the word Carina if you actually access, if you actually talk to it. Yeah, so it's called Carina now, CARINA.
Okay, good to know. Good to know. Thanks. Okay. And then wrapping up her project. This is, our personal experience has been, it can drag on for quite a while. We will get you the data that we see in Clarity or in STARR, but we have found that doesn't mean the data is there. So I think Joe's mentioned, in theory, that stuff is supposed to be there, but it's not always filled in. So we can help you with the revisions, finding other places where that data might be stored, or trying to clean up, errors where, I don't know, if somebody put in kilograms for pounds or something like that, we can help clean that up, identify some of the unexpected data. We have typically people have questions about, like, okay, well, I didn't realize the data was going to look like that. So can you take out these things, or can you add this other thing I want to look at? Now I want to look at breastfeeding and stuff when I was just looking at baby temperature. And then often people come back to us like a year later and say, okay, I want to add these new patients, or I want to create a control group with similar characteristics as the patients in my original cohort. So you can come back to us for that after. And just a heads up that may require some additional funding, or you may need to kind of find yourself back at the end of the queue after that. Okay, and that caveat, the data's messy. One of the things I've been finding is that the things change over time. So if you're only looking at a year's time, that's probably pretty stable. But when I've looked at projects that span a decade, and things change over time. and there's different ways of doing things. The departments changed names. We have a lot of different people entering the data, and they've got their own little nicknames for things. We were looking at the radiant heater for babies. I think somebody called it a French fry heater. So you've got a lot of different data entry users. So you have to be wary of that. And as you're looking at the data, we can get you what's in there, but you're going to have to do a lot of cleanup typically as you're going through the data. And then this is an actual project that we can go through. Were there any questions before I go into the?
No, not.
Okay. So this is actually, I don't know, last talk I gave, this was actually kind of informative to see what it looked like for a project that I've been working on as a paid data consult, so a concierge service, what that looks like, what we can do that may be harder to get if you're doing the self-service tools. So I was working with Dr. Rebecca Dang on newborn nursery. She particularly wanted to look at hypothermia. She wanted to go all the way back 2014, which, that crossed over into, I think, I don't know if it's HL7 or a different system where data was brought in from, and we had like the temps, but some of the the way they did things and the kind of data that recorded was not consistent throughout the project or over the time period. So we pulled the demographics. Those are typically pretty straightforward. This was a little bit different because it wasn't just the patient, the baby. We also wanted to get information about the mothers. So we got the maternal age when the baby was born. We wanted delivery data. So how old was the baby gestationally when it was born, birth weight, delivery method, cesarean or vaginal, flow sheet data, the temperature of the baby, weight. There's, flow sheets cover like a wide thing. So we wanted radiant warmer, phototherapy for, jaundice. She wanted to have the encounter data. So the admit discharge, when the babies were moving from, delivery to the newborn nursery or to NICU or to someplace else, like sometimes they were going into surgery. When the babies were reunited with their mothers in the same room, if there were readmissions. And then we also looked at some of the diagnoses, the chorioamnionitis for the mothers, hypothermia for the babies, and sepsis and the hyperbilirubinemia. And then she also wanted to have get some data around the bath times because that affects the temperature of the baby, whether they were being put into isolate use, the gravida para, which should be in flow sheets, but is not always, the feeding, what the plans were for the feeding, what was being done in terms of breastfeeding, et cetera. I just went through all those. Now, this project I'm still working on it, actually. We have found that there's just quite a lot of data that should be there. Like, for example, birth weight, she was like, that should always be recorded. But it's not always recorded in the place that it's supposed to be, is what we found. Or we found that she wanted to know if the baby was born in the hospital versus someplace else and then brought in from home, or was born at home and then brought in. And that turned out to be quite difficult. There are places where those data are stored, but they're not always accurate, I would say, or not always filled in, not always reliable. So I ended up having to pull a bunch of different things from different sources. Also, the researcher, what we needed the researcher to do was to take a look at these different sources and figure out, okay, given I've got all this conflicting data, what do I want to do to identify this patient, whether they've been born at home or in the hospital? So that required some discussions around that. And then we also found that, the NICU was not always called NICU. It was called different things. And, it used to be D2 or something like that. She had to go back and talk to some of her advisors to figure out what was going on back in 2014 and how things were being done.
So that reinforces all of our points about the importance of considering a prospective study where you recruit patients and then you hire a clinical coordinator to track them in going into the future, because then you actually build up a coherent data set where every single variable you want is in the data set.
Yeah, so it will require you, if you do want to do retrospect, it's going to require you to do a lot of thinking about how to handle this messy data. It is possible to get you the data as it is in the system, but just be aware that that data may, we can guarantee that we can get you the data, but it may not be what you want, what you wanted it to look like. So it is going to require some work on your part to figure out how to interpret that data. So just recapping on how the process would work to connect with RSC, you would submit a request, take a look at that email response, sign up for office hours, meet with us, and we may need to do an extra session where we actually, maybe take longer than the 15 minutes to go through what it is you're looking for. Oops, I went backwards. We will typically ask you to go get that PTA along with the codes, figure out what codes or department names you want to consider. We pull the data for you, review it, do a project wrap up, and then get you the final data set for analysis. So that's the end of my presentation. We can go through some additional questions that you might have.
Yeah, so there's a question to see if I'm thinking about this generally correctly at all. Based on my question and proposed project, I was planning to use STARR to identify my initial patient cohort, but then use EPIC to find some of the more specific information that I need. For example, scan genetic testing will need to be reviewed. I was planning to use REDCap for data input. No patient enrollment though, just using existing patient data.
Yeah, so REDCap, I'm not sure if I'm understanding the gist of the question, but I often will coordinate with people, like, for example, the CT surgery group really likes REDCap. And so I will pull the data for them and I'll put it into REDCap. And that actually could be another source, place that I could put the data instead of Medicine Box or GCP. I can put the data into REDCap. Those are usually for smaller projects.
And so can the researchers. So yes, I think this researcher could use the self-service tools to get CSVs, which then imports into REDCap after a bit of cleaning, and then absolutely get that EHR access document filled out, and then do chart review to read the genomic PDFs, which are not available in STARR.
Yes,
and
that has
sounds like a solid approach to do a retrospective study.
Yes.
But do bear in mind that correlation does not equal causality. And if you spot data anomalies, it doesn't necessarily mean what you think it means. So you may need to do some additional research into the clinical workflows that produced the clinical data that you are looking at from the EMR before you really understand it.
So there's another question saying, thank you. Do you charge by project or by the hour?
So RSC charges by the hour. We can give you an estimate on how long we think it'll take. It's not really a not to exceed kind of estimate. It's more like how much we actually think it might take, and we'll charge you whatever time we actually spend on the project. But we can give you a number for budgeting purposes.
We've got a few minutes left. Are there no more questions? I wonder if it'd be helpful, Joe, for you to go back to the cohort discovery tool and point out a few more features while Mina was talking about negation and, patient age at event. We kind of skipped over that in the initial cohort discovery. It might be handy to point that out.
Yeah, I can do here. Let's see. All these windows.
So you're so just click on encounter with and show them that there's a drop down there. So all of these constraints can be negated by clicking on the very first little drop down. And then all of these clinical constraints have age at event, event date is, and occurrence frequency is as additional additional things that you can supply about this. So if you were looking for a patient population between the ages of 7 and 25, you would type that into each one of your constraints there under age at event is. Because be leery of using current age. Current age is literally how old they are today, which doesn't really cast any light on how old they were at the time when the sentinel event of interest took place. So you really want to use age at event when trying to filter for a patient population of a certain age range. By the same token, event date, we looked at it briefly earlier, but you can use that to bracket your data pool.
So if you wanted to look at things that happened before COVID, for example,
right, or during COVID, you could use it between November 2019 and whatever it's March of 2020. Occurrence frequency is a funny one. We added it in because sometimes we found that diagnosis codes that only appear once are less reliable than diagnosis codes that are repeated through the patient's journey through the EMR. So we had back to this project where we were trying to find women who had actually had breast cancer. One thing we tried was to make sure that they had at least 3 different codes and different dates of breast cancer. What was the other thing that I wanted to?
And sometimes, going back to identifying people who actually had that thing, they'll identify the patients who had needed to have like a certain medication or procedure. That's another way that they might use to be sure to catch somebody that diagnosis.
Yeah, sometimes there are diagnostic tests that are standard of care for patients with a known clinical condition. So you can, type in HCT here and see what you get. So it's tiny, very hard to see, but you can see that HCT, that's the grouper, that's the base name. And so that is hundreds of thousands of lab results spanning, what date is that? 1990
to
so that
today,
group goes all the way back in time to the beginning of the record that we have here in STARR.
And the default here is to look for abnormal results.
Right. So you want to pull
there may be
that down.
cases where you're interested, if you're trying to figure out whether, you may be interested in whether someone had a test at all, which might give you some insight into whether a clinician was trying to rule out a condition. But an abnormal result is frequently going to be diagnostic that some specific condition was actually identified, even if there isn't a diagnosis code. But again, I'm not a doctor. I only play one on Zoom.
One more thing, change HCT to SARS and pull up an example of a qualitative lab. It's subtle, but if there's only positive or negative as the result, there should be a PCR test in there somewhere. Any one of those will do. You see how it says exists? Pull it down.
Right.
And then positive or negative. So that's what for the labs where it's either yes, no, we detected it or we didn't. You get that. Those are the options for that type of lab. Hematocrit is a numeric result, so you had a much more complicated set of filters. Are there any other questions before we've got 2 more minutes before we officially finish?
One of the things that I didn't realize is the count and how to do searches, all the things that are available under the searches folder.
Yes, that's a good idea. So you can save your search for later retrieval. You can look up searches that are saved to the library. There are more options here than most people see because Joe is an administrator.
Yeah.
But you can save your search for chart review and you can upload MRNs for chart review. But this is all in the documentation. It's well worth reading the user's guide. It's a lot of information in there.
I believe you have to press count before you can save the patient for chart review, right?
No, you have to have a valid. Yeah, it has to be a valid query. It has to be, the count button needs to be enabled, but you don't actually have to push it.
Okay.
So it's a good idea. It's a good idea to do a count because you may not have any patients, and right at the moment you may not actually know whether your patient count is 0 or just very small.
Oh, that's a good point. That's another comment. There's a tilde in front of all these counts, and that means that they're approximate. So when you actually save your cohort, even though it told you that you had approximately 350, it may only save 247 because that tilde means it's approximate. We approximate the numbers in chart review so that it is not, there's not so much specific information that you can triangulate a single individual. Well, it's 3 o'clock, or sorry, -3, it is noon. I think we should wrap this up. Thank you everyone for joining us today. Priya, you'll be publishing the...
I will, and if we can just take 1 more minute, there's a question saying, what does the upload STARR and non-IDs for chart review mean? If somebody wants to quickly take that, and then we'll wrap it up.
Priya, do you want to, this is an OMOP question. Where do you get the non-IDs from?
So, so actually you get a non-IDs when you de-identify. So the way I understand this is you get a non-IDs when you use the STRIDE codebook and you're actually de-identifying images.
Yeah, it's complicated. Talk to Mina in a consultation to find the answer. Is how we'll just have to.
Yeah. So if I understand this correctly, if you de-identify the data from STARR Tools and you get the de-identified patient in the STARR Tools, say chart review, would be, you would not have the person's name. You would actually have a non-ID.
No, so the upload is for OMOP. It's patient IDs, isn't it? Or is it an actual non-ID? That's why I punted the question to you because I assumed it was a reference to OMOP. Is it actually?
It says upload a non-IDs for chart review.
Oh, okay. Then.
Yeah.
I don't know what to
we have two upload mechanisms. One allows you to upload MRNs, which obviously are identified. The other is if you've gotten a set of IDs from the de-identified OMOP.
Right, from the RIC. You have to have had a consultation with the RIC to do a custom de-identification. And if what you have is a code book from that old consultation, then you can upload that to do chart review. But it's very unusual and new researchers will not be interested in it.
So I have Joe. Joe, is he still here? Joe Nestor-Hazy. Am I actually allowing him to talk and making him a panelist? Joe, are you here?
I'm here.
Yeah. So I mean, and maybe this is something that would be good to clarify. So if it's de-identified STARR OMOP data, they are called person IDs. They're only called non-IDs. I've only seen them in the context of de-identified images, which is a different code book. So it's nothing to do with STARR OMOP.
Yes and no. So if you have a de-identified data set in STARR OMOP, in the OMOP database, the person ID is the identifier for that person. But for all those person IDs, they do have an anonymous ID that has been created in the STARR database. It's just currently not exposed in the STARR OMAP that's delivered, but it does exist. And that means if you have a data set created, de-identified in STARR OMAP, and you request imaging to be delivered with it under that same IRB, then the images will have the same anonymous ID mapping as OMAP. And we can always provide a link between the two so that you know which anonymous images go with the anonymized OMAP.
So a non-ID is always linked. There's a one-to-one mapping between a non-ID and a DID person ID.
Yes. Yeah. Yeah. And we're looking at putting the non-ID in OMAP under the person source value. It's just on the roadmap. So that can't, there's no reason not to expose that to everyone. So.
Okay, so that's just a suggestion. Now, can you upload STARR OMAP, I assume DID person IDs, to use the chart review tool based on cohorts we've created in STARR OMAP? But yeah. So
There'll be some compliance questions to answer there, because I think the idea originally was that you would never be allowed to re-identify. So the risk would be that somebody would use a de-identified STARR OMAP and keep that data and then go get an IRB and then re-identify them, which would break your terms of service. So it's possible that even though it's technically feasible, we may decide by policy to not enable it.
All right, thank you, everyone. I think it's 5 past noon. Thanks, Susan. Thanks, Mina. Thanks, Joe. Thank you, everyone. Thanks for joining. As I said before, I will post the recording in a couple of days. And thank you, and we'll see you at the other workshops. Bye.
Thanks.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.